Assalamualaikum warahmatullahi wabarakatuh. I would like to say thank you for coming to this presentation. It's an honor for me to be here. In this presentation, I will explaining about pediatric hearing impairment, management, necessity, and obstacle. As we know, hearing loss is a common condition presenting in children. Speech and language outcome for children with hearing loss are related to identification of the hearing loss and to degree of hearing loss. Early identification and appropriate prompt intervention for a better outcome. Hearing loss is defined as cannot hear the sound, partly or totally unable to hear the sound. A basic knowledge of the auditory system is needed to understand how to appropriately intervene in childhood hearing loss. Essentially, there are four components: the outer ear, the middle ear, the inner ear, and the auditory nerve. The outer ear is a sound wave collection funnel. Its shape and configuration provide some enhancement to incoming sound, but the effect is minimal, approximately 5 decibel. The function of middle ear is to interact with the tympanic membrane. They cause a vibration of tympanic membrane that moves through the ossicle. Inside the cochlea, there are three distinct spaces that run its length. An electrical potential exists between the two fluid compartments and is essential for generation action potential along the cochlear nerve. This action potential are carried by the auditory nerve through various centers in the brainstem and the auditory cortex for higher level processing. Obviously, a defect anywhere along this path could cause the hearing loss. Prevalence of hearing loss in children is very variation across the country. From the study, it is within 1 to 5 in 1,000 live births affected with severe to profound permanent hearing loss. In intensive care units, it is approximately between 10 to 15 from 1,000 live births. As children age, the prevalence increase. And by age 18 years, 17 in 1,000 individuals are affected by some degree of permanent hearing loss. This number, however, do not take into account all the children who are affected by long-study chronic affection, which, too temporary, can have a significant effect on the speech and language development if not identified and appropriately. In Dr. Zainal Abidin Hospital in Aceh, we found 127 case children with hearing impairment between 2018 until 2021. Hearing loss in children can derive from many forms. It can be congenital or present at birth, genetic, syndromic, non-syndromic, acute, and or progressive. It manifests as conductive sensorineural or mixed hearing loss. The evaluation, diagnosis, and management of children with hearing loss will involve a multidisciplinary effort by pediatrician, otolaryngologist, audiologist, deaf educator speech and language pathologist, early intervention specialists, and many others. The main focus of care should always be providing appropriate communication strategies to the affected individual. Approximately 50% to 60% of our prelingual hearing loss is genetic. Of this, 70% of non-syndromic form of hearing loss. The most common type of non-syndromic hearing loss is autosomal recessive in 75% to 80% for more. The most common type of non-syndromic hearing loss is caused by defect in connection 26 compression. Approximately 50% of all non-syndromic autosomal recessive hearing loss. As discussed above, non-syndromic hearing loss is the most common. Defects have been found in our inheritance pattern. To date, More than 60 different genes, Luci, have been identified that can cause hearing loss. In contrast to non-syndromic hearing loss, where there are typical no other associated physical findings. Syndromic hearing loss have various other physical findings that are apparent. Again, syndromic hearing loss is present in all modes of inheritance, more than 500 syndromes that includes hearing loss has been described. Of the remaining 50% of cases of congenital hearing loss, 25% are caused by non-genetic factor. The most common acquired from the congenital hearing loss is cytomegalovirus infection. Another infection, origin being particular common, bacterial meningitis, particular from Streptococcus pneumoniae, may lead to hearing loss. Hearing loss typically occur early in the infection, can be mild to profound, and can often to prevent it or improve with early and prompt antibiotic therapy. Other causes of acute hearing loss include trauma, particular temporary bone trauma, fracture through the cochlea, and vestibular can result in severe to profound sensorineural hearing loss. Fracture to the ossicle can disarticulate this bone, causing moderate conductive hearing loss. Acoustic trauma, noise-induced hearing loss, can also cause permanent hearing loss. The earlier the diagnosis of hearing loss can be made, the sooner intervention can be initiated to help the child develop. Currently, our state have a universal newborn hearing screening program and early hearing and detection and intervention program. In 1993, only 12 hospitals in the United States screened more than 19% of their newborns. Since this time, there has been incredible expansion of the program, such that in 2012, a total of 97% of our children. Formal audiometry screening and evaluation with autoacoustic emission and auditory brainstem response should be done in case of there is possible diagnosis, such as auditory neuropathy. It is because of this early identification effort that intervention are able to be early in child life. The goal of this program is to screening before age of 1 month, identify all children with a permanent hearing loss by age 3 months, initiate appropriate intervention by age 6 months. Once hearing loss is identified, steps should be taken to minimize the duration of hearing loss and or maximize the function of the residual hearing or cochlear function. In addition, effort should be made to militate against deficit in the other sensory system. The overall goal, especially in children, are to minimize the effect that the hearing loss will have on speech and language development and to provide appropriate strategy for communication. In general terms, the more pronounced the hearing loss and the longer the duration of hearing loss without intervention, the more significant the effect on speech and language development. All the management strategies and consideration are specific made for specific condition of the child. Children with permanent hearing loss can be examined with ophthalmology evaluation. Children with moderate or greater bilateral sensorineural hearing loss can be examined by electrocardiography. Then, children with otitis media can be medical intervention or myringotomy. And the last, children with mild or moderate hearing loss can amplification. It is important to make sure that the children with hearing impairment are getting the appropriate service. The obstacle of pediatric hearing loss are parent attitude are due to their concern about stigma associated with hearing aids that result in delayed and less frequent use of the device, which compromise their effectiveness. Socioeconomic factors also have significant influence in the effectiveness of hearing screening programs, especially in developing countries. In the countries where universal screening is based on OIA tests only, and if there are not any respector, children are not referred to AABR exam and are not diagnosed in a timely manner. Another significant weakness of universal newborn hearing screening program is the percentage of newborn that did not pass the initial testing but did not have any further testing and were lost to follow up. The conclusion in this topic is children with hearing loss definitely require rehabilitation. The sooner they are detected, the sooner they will get the right intervention. Delay in establishing a diagnosis that occur due to limited facility in undergoing the universal newborn hearing screening and targeting newborn hearing screening programs. The combination of OAA and AABR testing, which provide the most accurate diagnosis of hearing loss and significantly reduce the referral rate, should be considered to be in the future a standard protocol in newborn hearing screening. The gold standard of universal newborn hearing screening should be nationwide screening, prearranged according to the guideline of the Joint Committee International Hearing. Program should guarantee close cooperation between maternity units and audiological center in order to decrease time between exam, eliminate unnecessary tests, and assure proper intervention. This is the end of my presentation. Thank you for your interest and attention on this topic. If there is any information and question you'd like to know, please feel free to ask me. Thank you.